Welcome to the Endocrine Matters podcast. This podcast episode is sponsored by Complete Medicine and Hey Healthy. Hello, and welcome back to Endocrine Matters. I'm Dr. Arti Thangudu, endocrinologist, diabetes specialist, and someone who truly lives and breathes blood sugar. I want to start today by being very honest about why this episode feels so important right now to me. Over the past couple of months, I've felt strongly called back to type 1 diabetes awareness in a deeper, more urgent way than I have in a long time. In my clinic, I've met new patients with type 1 diabetes who are new to me, but have been living with type 1 for a long time, who have had substandard care for decades. Not because they didn't care, not because they weren't trying, but because no one ever really taught them how insulin works in the context of real life, with food, stress, sleep, illness, hormones. At the same time, my own family members have been newly diagnosed with type 1. And when type 1 diabetes hits so close to home, you can see the fear and overwhelm in a very different way. You feel how heavy the responsibility is, how constant the decisions are, how lonely it can feel. And I've become acutely aware of the huge lack of local community support for kids and adults living with type 1, for parents, for teenagers, and for people transitioning into independence, those kids in college with type 1. All of these things together made something very clear to me. We are still not empowering people living with type 1 diabetes the way we should. Over the last more than decade, I've cared for hundreds of people living with type 1 diabetes in the hospital, in clinics, through surgeries, infections, steroid treatments, pregnancy, puberty, burnout, grief, and just everyday life. I manage blood sugars when people are critically ill and when they're just trying to get through a normal workday. I feel like I live and breathe blood sugar. I think about it all the time. And if there's one thing I want you to hear clearly from the very beginning of this episode, it's this. High blood sugars are not your fault. They're not a patient's fault. Low blood sugars are not a moral failure. These are parts of learning how to care for a body that needs insulin to live. Type 1 diabetes cannot be managed well from the outside. Insulin needs change with food, exercise, sleep, stress, hormones, illness, steroids, emotional state. No doctor, no insulin pump, no algorithm can fully understand all of that without the patient at the center. The patient has to participate. This is why I believe so strongly that patients themselves, even little patients, must be involved in insulin decisions, all of them. When people start to understand why insulin doses are adjusted, fear decreases, shame fades, confidence grows, and the goal is not perfection. Type 1 diabetes does not offer perfection, perfect blood sugars all the time to many people living with it. The goal is for people living with type 1 to understand insulin well enough that they can begin to make small, safe, intuitive adjustments based on what they ate, how they moved, how they slept, how they feel physically and emotionally. That is empowerment. So let's ground this in the basics of insulin. First, we have basal insulin. Basal insulin is like your background insulin. It suppresses glucose production from the liver and keeps blood sugar stable between meals and overnight. At least that's what it's supposed to do. For most people with type 1 diabetes, basal insulin makes about 30 to 50% of the total daily dose. Basal insulin should hold blood sugar steady. It should not cause big drops overnight. It should not require feeding overnight. If you are always needing a snack overnight or right before bed, that probably means that you have too much basal on board, what we call over-basalization in endocrinology. Second, we have bolus insulin. Bolus insulin is that short-acting insulin that most people living with type 1 diabetes take at mealtimes. Bolus insulin does two things. It covers carbohydrates at meals, and it corrects high blood sugars. We think of these two pieces of bolus insulin separately. Understanding this distinction is essential for making sense of patterns. One of the most common misconceptions I see is this. My morning blood sugar is high, so my basal insulin must be too low. I must need a higher dose of basal insulin. While that might be true, it is not always true. So let's walk through a couple of examples. Scenario one, let's say you went to bed high, say 220, and you wake up at 215 the next morning. Your basal insulin actually did its job. Your blood sugar stayed stable overnight. What you needed was an evening correction bolus, not more basal insulin. Increasing basal in this situation would probably lead to overnight lows, perhaps rebound highs after a low, dangerous hypoglycemia overnight, or even possibly throughout the day. So let's talk about a second scenario. Let's say your blood sugar dropped overnight. Your body may release glucagon, a counter-regulatory hormone that raises blood sugar. So you may wake up high because you went low, not because insulin was insufficient. In fact, you had too much basal insulin on board. This is why we focus on patterns, and we have to take a patient's day-to-day life into account when making decisions about insulin dosing. We can't make big changes just on a single number. I want to be very clear about this. Low blood sugars are more dangerous in the short term than high blood sugar. Everybody is scared of high blood sugar. I think culturally we know that high blood sugar is bad, but high blood sugar, yes, it can be harmful to our organs in the long term, but a low blood sugar can harm you in the moment. Severe hypoglycemia, low blood sugar, can cause accidents, passing out, seizures, even death, and it can happen quickly. That's why clinically, in endocrinology, we always tackle lows first and only then work on bringing down highs. This is why using a device like a CGM can be really helpful, because a CGM tells us about what the blood sugar is doing minute by minute. It gives us time and range. An A1C can be very misleading because an A1C is an average of 3 months of blood sugar. So an A1C that looks good, maybe like 5.7 or 6%, looks good, but a patient may be having frequent 40s and 400s, and it's all averaging out to a number in the low 100s, whereas someone may have an A1C of 6.8, 7%, and have a steady blood sugar that is actually safer than that lower A1C with lots of peaks and troughs. High blood sugars in the short term are uncomfortable but unlikely to cause immediate damage. High blood sugars over many years, though, can affect eyes, kidneys, heart, nerves, but safety always comes first. Once we knock out the hypoglycemia or the low blood sugars, then we can address bringing the highs down. Two key concepts help guide bolus insulin decisions. This is your short-acting mealtime insulin. Insulin to carbohydrate ratio, or ICR. This tells us how many grams of carbohydrates are covered by 1 unit of insulin. So let's say you have a normal blood sugar and you are about to eat. We use the insulin-carb ratio to determine how many units of insulin you need to bring your blood sugar back to where it is right now, given what you're going to eat. A common starting point in type 1 diabetes is around 1 unit of insulin for every 14 or 15 grams of carbs, but this varies widely. Some people need 1 unit for every 20 grams of carbs. Others need 1 unit for every 10, or even 1 to 5. There is no right ratio, only the ratio that works for your body. Sometimes this changes throughout the day. Sometimes you need more insulin to cover your carbs in the morning than in the evening. And this is where insulin pumps can be really helpful. We'll talk more about that later in this episode. The next factor that we use to help with bolus determinations is called the insulin sensitivity factor, or ISF. This tells you how much 1 unit of insulin lowers blood sugar when it's high. So let's say your blood sugar is 200, your insulin sensitivity factor is what determines how much insulin would be required to bring you down to a safer level, like 150. The 1800 rule is often used as a starting estimate, where we divide 1800 by your total daily dose of insulin, but real life is a lot more complex than that. So We have to understand something called insulin action time. It's usually around 4 hours for our most commonly used short-acting insulins. And we have to think about insulin stacking, which is when you take boluses too frequently. If you're having a high and then you're bolusing and then bolusing again, patients can have rapid lows. Insulin sensitivity increases with exercise and fasting. It decreases with weight gain, menstruation, higher fat diet. Even one higher fat meal will make you more insulin resistant or less insulin sensitive. So, insulin sensitivity is dynamic throughout the day, and pumps can be very helpful for this as well. Carb counting allows flexibility, but it's not the whole story because fat and protein delay digestion. So people who eat meals like pizza or burgers, they might have a less rapid rise in their blood sugar, but their blood sugar stays high for much longer. In these instances, if we gave all of the insulin for the number of carbs up front, people may have a low maybe an hour after they eat. So for pump users, features like split boluses and extended boluses can be really helpful. It's possible to do this with insulin injections as well, but not as easy because people with type 1 diabetes tend to be very insulin sensitive. So giving whole unit increments can be very potent. With pumps, we can give a fraction of a unit. For injection users, bolusing is about timing, trend awareness, more gentle corrections, because corrections with too much insulin can cause hypoglycemia. And then if you have hypoglycemia, you can have rebound hyperglycemia due to a glucagon response. Or, of course, people correct with carbohydrates when they have a low, but oftentimes people overcorrect and it leads to this roller coaster of blood sugar. This isn't failure, it's physiology, and it takes learning, time, and engagement. So let's talk a little bit about insulin pumps. Insulin pumps allow fractional dosing. That means you can give a fraction of a unit. So if you're very insulin sensitive, this can lead to overall better control because you're not having those highs and lows that are needing corrections. It also allows for adjustable basal rates. So when you are taking an injection of long-acting insulin, you take one injection a day typically, and that basal rate is steady throughout the day. But a lot of people are more insulin sensitive overnight because they're not eating, so they're essentially in a fasting state. So people actually need a lower amount of basal background insulin overnight than they may need during the day while they are eating, for example. Or when people are exercising, they may need a lower basal rate at that time because they're so much more insulin sensitive at that time. With an insulin injection, we can't really adjust at all throughout the day. So we just have to give the lowest estimated basal insulin dose that a patient might need to prevent hypoglycemia. Whereas with an insulin pump, we can change the basal rate hour by hour to ensure that we are giving the correct basal rate for that time. And the patient doesn't have to make decisions about this. It's just set in that way. And now we have pumps that adjust basal rates based on how the patient is responding. Insulin pumps allow for precision for insulin sensitive individuals with varied insulin sensitivity factors. They have active modes to prevent hypo during exercise. You can literally just switch it into active mode when you're exercising and it lowers your basal rate. It also gives patients extra boluses when they're running high without an additional shot. So it's pretty inconvenient to be going about your daily life and recognize that your blood sugar is 250 and then have to stop and give yourself an injection. But with a pump, you don't have to get out a needle or anything. You can just give yourself an additional bolus. And now with hybrid closed loop pumps that talk with CGMs, it may just give you that additional bolus without you having to think about it at all. CGMs, continuous glucose monitoring systems, CGMs give us blood sugar data every couple of minutes. So instead of having to prick your finger a few times a day, CGMs painlessly give you insight to your blood sugar all day and all night. They warn you if you're going low. And they also now talk to hybrid closed loop insulin pumps to help prevent you from going low. When the pump sees that your blood sugar is falling rapidly, it stops delivering insulin, for example, or if it notices that you're high even after you bolus for a meal, it'll calculate how much insulin that you need to bring you down back into range. And it can do this in fractions. So, maybe you need 0.3 units to bring you back into range. It enables you to do that without even thinking too much about it. So with the CGM though, they're not perfect. At very high highs or very low lows, fingerstick confirmation is essential. That means you still have to poke your finger and get a capillary blood glucose because CGMs read interstitial fluid. That's the fluid between your cells. And it's a pretty good estimation of what your blood sugar is, but it's not as accurate as a blood sugar. And when you're making insulin decisions based on the data that you're getting, it's really important that that data is accurate because making decisions on inaccurate data can be extremely dangerous. That said, hybrid closed loop systems where insulin pumps talk to CGMs have been a game changer. I've watched the transition from old pumps without CGMs to systems that dramatically reduce hypoglycemia, severe hyperglycemia, and most importantly, mental burden for patients and their families. Patients just don't have to make as many decisions by themselves about insulin dosing as they used to with these new hybrid closed loop pumps, and they don't have to have as much fear about dropping low. And that ease of mental burden and hopefully reduction in diabetes distress is huge. Parents, especially moms, have told me I can finally sleep at night. That's huge. Most moms or parents with children with type 1 diabetes are constantly in fear of hypoglycemia. Having the technology that makes that fear a little less heavy is so incredible to see. One of the hardest times for many patients is the transition from childhood to adulthood. This is when parents step back, independence increases, structure starts to disappear, and young adults want to fit in. They want to be normal. They don't want to deal with diabetes, which all makes perfect sense. So if you're in this phase and struggling, hear this. This is a hard season. There is a lot going on, and it will get easier. Once people reach their mid-20s, something switches in their life and their brain, and things just tend to get a little bit better. And for parents with children in this season, your support matters even when it frustrates them. So the goal is not perfection. The goal is understanding, it's learning. When you understand insulin, your body, and your patterns, you can respond with care instead of blame. You can respond with confidence instead of fear. Type 1 diabetes is demanding, but it does not define your future. You can live a long, happy, healthy life with type 1 diabetes, with education, with support, with compassion, with community. And that is what we are here to build. Thank you for being here. Until next time, take care of your blood sugar and take care of yourself. If you'd like to be our patient, you can find us at essaycomplete.com. If you like this episode, please subscribe to our channel. Your support means the world to me. And if you'd like to follow me on Instagram, you can find me at Dr. Arti Thangudu.